It's great to see everybody. Many of you I already know, and I really appreciate this time to chat with you. I thought we'd kind of keep it down to the basics here today. Really, talk about heart problems and what they are. How do I know if I'm at risk? How do I lower my risk? And, maybe how can I tell if I'm having symptoms that are a problem, and does that differ if I'm a man or a woman? Hearts can run into trouble in a number of different ways, but the most common way that Americans run into heart disease is with coronary artery atherosclerosis, or buildup of cholesterol plaque in the arteries. And so for a short talk, I think I'll focus on that. Back in the 1960s, we were able to do some studies that really identified 5 basic risk factors for developing atherosclerosis, this infiltration of the walls of the arteries with cholesterol, fatty material, inflammation, some calcification, and which can lead to narrowing of the arteries, restricting adequate blood supply, so when the heart's working harder, you get short of breath or chest pain, or actual swelling and bursting of that plaque, a clot, and a total blockage of the blood flow downstream, which can lead to heart attack, and sometimes deprive the electrical system of the heart of blood flow, leading to a sudden irregular heartbeat or sudden cardiac arrest, sudden cardiac death, which is, of course, the most feared complication of coronary disease. So these 5 risk factors that we identified, everybody knows pretty well: high blood pressure, high cholesterol, diabetes, cigarette smoking, family history. By family history, we should all really know that that is primarily restricted to early onset of symptomatic atherosclerosis in a first-degree relative, a parent or a sibling, male under the age of 55, female under the age of 65. So if you had a grandmother who had a heart attack when she was 88, or if your aunt had a problem at an older age, that really doesn't move the needle in terms of your risk compared to the general population. Cigarette smoking is a tough thing. All I can say is try not to do it if you can avoid it. Vaping is not good. Marijuana smoking is not for free either. Hypertension, diabetes, and cholesterol. So we identified these 3 factors, and yet since the 1960s, we've learned a lot more. There's a lot of genetic tendencies toward these problems that we're understanding better and better. One group of, actually large group of people have a tendency to put on weight specifically around the middle, both between the skin and the abdominal muscles, and also inside those abdominal muscles around the organs, we call it visceral fat, which tends to give us a protuberant abdomen. The people who have that tendency also tend to develop resistance to insulin. Insulin is the hormone that helps sugar get out of the bloodstream into the cells for energy and growth and all the other things that cells are supposed to do. And when we become resistant to insulin, we tend to move toward type 2 diabetes. It's associated with high blood pressure and with specific changes in the cholesterol. Not just an increase in the total amount of cholesterol, but a high amount of triglyceride, a low amount of the good high-density lipoprotein cholesterol, and a change in the bad stuff, the low-density lipoprotein. So in people with that problem, the low-density lipoprotein particles floating around the blood are actually smaller and denser than in other more healthy people. And they act more aggressively to build up inside the arteries and start atherosclerosis. So we know that that group of people have to be very, very careful. Diet, exercise, and very, very often medications are required to kind of counteract those tendencies. We know other things about the genetics of atherosclerosis and cholesterol in particular. There's a problem we call familial hypercholesterolemia, which means inherited high cholesterol in the bloodstream. And most of these people have a defect in the protein receptor that sits on the liver and pulls LDL cholesterol out and recycles it. So if we have familial hypercholesterolemia, the cholesterol gets out of the bloodstream and it never gets taken out, and that builds up to a point where these people are at high risk. It's also something that is sort of more stealthy than very high cholesterol levels, which is something we call lipoprotein A. It's been in the news a lot lately, and you may see this. Lipoprotein A masquerades as low-density lipoprotein cholesterol. So when we do a standard lipid panel, it breaks down into high density and low density. In some families, there's a cholesterol and protein particle called lipoprotein A. It has a different protein carrier than the usual LDL, and it is a much worse actor. And so for any degree of LDL that we see in your panel, if you have inherited a high amount of lipoprotein A, you're more at risk for heart attack, stroke, aortic problems. And that's something that you don't find unless you check it. So we're checking it more and more. And in families who say, geez, my father, my grandfather, my great-grandfather all had a heart attack when they were 40, sometimes you find out that they have a very high lipoprotein A level. And so it's something to keep in mind. It really only needs to be checked once in your lifetime. You either got it or you don't. There's not a specific treatment today for lowering lipoprotein A in a way that reduces heart attack and stroke. But there's a medicine on its way. Stay tuned, I'll talk about it in a minute. So that's sort of how we can tell if we are at a population risk. Other ways are really just to ask the question, well, do I have it? We can do a CT scan of your chest, looking for calcium deposits along the walls of the coronary arteries, which in intermediate risk people is a way for us to say, well, not just are you and 30 million other people likely to have a heart attack someday, but are you growing up plaque in your arteries today? And so that's a really nice way, inexpensive, to identify atherosclerosis when it's there. Really helpful for a middle-aged person with kind of slightly high cholesterol, weighs an extra 10 or 15 pounds, blood pressure is borderline, how much should I nag? And so very, very useful both for a doctor and a patient. So then how do we lower our risk once we find out that maybe we're going to get this? I didn't mention that getting older is also a risk factor. I wanted to be invited back. So, I will say though that coronary artery disease, having a heart attack, is not a character flaw. It is not something that we have entire control over, and really just part of the normal aging process. In addition to these risk factors, is some some wearing out of parts, and so it's not all what we can do, but we can lower our risk, and that really gets down to what should I eat, what should I do, and maybe what should I take if medicines are appropriate. There's more heat than light in the diet industry. And a lot of people will try to sell you stuff or get you on their program so that you will buy the product and do it. Billions and billions of dollars at risk or at stake here. But some principles apply. We find that people do well when they eat foods that look like plants that were growing in the garden yesterday, or that they were part of an animal that was prancing around a pasture. And the less that it looks like real food, the worse off you probably are, just for a rule of thumb. We tend to favor a description we call the Mediterranean diet, which focuses on whole grains, fruits and vegetables, healthy fats, lean proteins, not a lot of processed food, but meat, chicken, and fish, and not a lot of added sugars. That tends to be a high fiber diet, and getting fiber in your diet has several beneficial effects. It helps it helps you maintain a healthy gut bacteria population, which is being understood more and more to be very, very crucial to all sorts of health, including heart health. Slowly digested foods make you less hungry. And the typical American diet, which is sugar and finely milled flour and pureed everything and cellophane wrap this and that, tends to go in, be burned very quickly, lots of sugar in the bloodstream, then stored as fat, and then gone with a big insulin release, and we're hungry 90 minutes later. A recent Harvard School of Public Health study showed that when they took two groups of people and put one of them on a typical American processed food diet and the other on a Mediterranean style, more natural diet, the processed food group ate 500 calories more every day. And I think of it as in your fireplace, if you throw paper and kindling on the fireplace, it burns very brightly, but then it goes out and you have to restoke the fire in order to stay warm. Whereas if you put a big log on your fire, it'll burn all evening and you don't have to go back to add more. And we really see that when people change to a Mediterranean complex carbohydrate-based diet, that they can make it from breakfast to lunch without snacking. They can make it to dinner, and then they don't have to eat at night until morning, and they lose weight because they're eating less and they're satisfied. And it's not this white knuckle trying to avoid eating every moment that so many people go through, but is, can be very enjoyable and a great way to eat and a way to lose weight and be healthy without spoiling dinner time. Now, let's face it, one of the reasons we don't want heart disease is so we can live to be 99 years old and enjoy meals with our family and friends. And food should be a good thing, and it shouldn't be the enemy. And good food is really our friend. So be aware of what you're eating. Look at your grocery cart when you're checking out, and just kind of take a look at what's in there. Is this really what we want? So then what should we do? What should we do? And exercise, I always say, exercise is the fountain of youth that everyone is looking for. And it doesn't have to be dressed in a certain way with a gym membership and a sweatband. You should do what you will do. And you should do what you will like. If you like dancing, we have studies that show that people who dance have less heart disease. If you like walking with your friend, that's a great social thing, and it gets you out there because he or she is counting on you. And gardening has been shown to reduce the risk of heart disease. Plus you get whole fruits and vegetables. So exercise is good. The physical activity guidelines for Americans is 150 minutes, so 2.5 hours of moderate exercise, or 75 minutes of vigorous exercise. Great. There is a very low threshold for where the benefit starts. A study that came out last month showed that at 2,500 steps a day, which is like a total of a mile throughout the day, they saw an 8% lower all-cause mortality decrease. At 8,700 steps a day, now we're walking 3 miles, 60% less death in that group, which is, where do you get that? I mean, you can't get that from any of the pills I'm going to be pushing later on in the talk. So, and actually interesting, and what I really liked to see in that study was that there was a plateau after that. After people got to 8,700 steps a day, which is walking about 3 miles a day, 3.5 miles a day, there really wasn't too much of a cardiovascular benefit over that. So, if you're going to go out and run a marathon, you could get stronger muscles and you could get lean and you can, have better fitness, but you may not be actually reduce your risk of heart attack any further. So it's achievable for us. And I thought that's really a nice concept. So, so then along with diet and exercise, is there a role for me beyond just as a, you know, a cheerleader here? And for some people, yes. I mean, there are people who are very blessed to have, you know, to have a metabolism that keeps all those risk factors under control. They have, you know, a commitment to diet and exercise. They really don't need medicines, and that's fine. But diet and exercise are limited for many of us. And especially when our goal now is to live past retirement age and be healthy, the doctors in this business are really focusing on our health span, even more than on our lifespan. We want to maintain the maximum number of active, productive, happy years. And there is a role for medicines in heart disease in doing that. So I'll say briefly about high blood pressure. Fix your high blood pressure. When your arteries are under higher pressure, 100,000 heartbeats a day for years and years and years, they wear out. Not only here, but here. You end up with strokes, you end up with kidney failure, and you end up with heart attacks. And it typically takes 2 or 3 different medicines all working together to control blood pressure in the average person, so don't be discouraged or disappointed. And then the other thing I will say is that the most effective blood pressure lowering medicine that we have is weight loss. It's always effective. It doesn't interact with other medicines in a bad way, and you don't have side effects. And I can't say that about any medicine. Salt restriction to a degree as well. What about cholesterol? A lot of us have, you know, imperfect cholesterol, or even if our cholesterol looks pretty good and we develop heart disease anyway, we need lower cholesterol. We can start sucking cholesterol out of the plaques in your arteries very easily with cholesterol lowering medications. We use the statin medications as a backbone for our treatment because they are effective, they work well, they have been shown to reduce risk of heart attack and stroke in people who are at risk. You know, we get a 30 to 40% reduction in your heart attack risk with a statin if you have coronary disease. Not quite as good as 8,700 steps a day, but pretty darn good. Statins have a bad reputation out there. You know, on the internet, everybody talks about problems with statins. It is true that people who take statins can get muscle aches. It's also true that, and this is really interesting for us, if people expect to have a problem with a statin, they are much more likely to have a problem than if they don't expect it. There's a totally cool study that they took people who had failed a statin because of muscle aches, and they gave them sets of 3 jars. One had a statin, a atorvastatin in it, one had a placebo in it, and one was empty. And they said, okay, they mixed them all up, and they said, okay, you're gonna take this one for a month, this one for a month. And they went through it 3 times. And the people who were taking the statin had a certain level of muscle aches. It was about 16%. The people who were taking the placebo had about 15%, had to stop it because of intolerable muscle aches. And the people who had the empty jar, only about 2% of them had muscle aches that were so intolerable that they couldn't put up with an empty jar. And the point is, we all are old enough that stuff is not the way it was. You know, that hurts. And so, you know, I don't want to minimize the potential for medicines to cause problems. 1 out of 250 people take a statin develop elevated blood sugar, and the muscle aches are real. But the most important thing is the implied contract that occurs between a patient and a doctor when a medicine gets prescribed. What that contract says to me is, I'm going to give you what I think is most likely to be the best thing for your problem if you are like most people who kind of look like you. And what you're gonna do is tell me, okay, but I'm only one guy, and that doesn't work for me. And I don't get my feelings hurt. I say, terrific. I'm gonna go get you another pill, and we're gonna try it. And not to get frustrated and say, that doctor doesn't know what he's talking about. He hurt me, I'm gone, and I'm not gonna treat my problem. But to realize it has to be some give and take, and I can only make an educated guess as to, like I said, what's most likely to be helpful for somebody like you. I always liken it to the shoe store. You know, if it's snowing and you go into a shoe store and you try a pair of shoes and it hurts your feet, you don't walk home in that pair of shoes, but you also don't walk home barefoot. You tell the salesman, go to the back room and get a couple more pairs of shoes, and let's keep trying them on till I get one that fits me and I like the style and it feels good and protects my feet on the way home in the snow. So that's how I feel about all that. We are also very lucky to have more and more effective cholesterol lowering medicines. And I'm going to throw a bunch of names at you. There's a medicine called ezetimibe or Zetia we've had for a while. Works a different way from statins, really amplifies the effects of statin therapy. So if people are only comfortable on a low dose or get to a high dose and still need more help, ezetimibe is the first thing we go to. It's cheap, it's easy, and doesn't cause a lot of side effects. We have medicines called PCSK9 inhibitors. I'm not doing slides here, don't worry about it. But there's Repatha and Praluent, the brand names of these two medicines, which are an injection once every 2 weeks that helps that LDL receptor on the cells I talked about earlier pull more cholesterol out of the bloodstream. And so you get rid of it faster. Very effective and shown to reduce heart attack, stroke, and cardiovascular death. There's a new medicine called Nexletol, also called bempedoic acid. It works at a place upstream from where the statins work in cholesterol manufacture in your liver. And right now it's really expensive. It doesn't lower cholesterol quite as well as the statins, but it's really helpful for people who can't take a statin and still need that effect. It's going to get cheaper as time goes on. And then there are two really cool medicines which are based on RNA, which is the genetic material. So there's a medicine called inclisiran, which you get an injection once every 6 months, it'll knock your cholesterol down by half. And it goes in by turning off the gene for production of one of the proteins in making cholesterol balance. And there's another one that I alluded to earlier, it's called lepodisiran. It is going to be the first medicine, goes in and turns off the gene for producing lipoprotein A. That's stuff that affects certain families. And that's a place that we haven't been able to really treat yet. Currently, our treatment is just maximize lowering total LDL cholesterol, high dose statins, all this other stuff. But this stuff is proven to lower lipoprotein A levels by 80 to 90% for close to a year after one injection. And so it's in trials now, and it really works, and it has side effects, and really shows that it lowers risk of bad outcomes. Then it's going to be out there, and we will welcome it. So, diabetes. Treatment of diabetes has come a long way. People used to get diabetes and then die of, insanely high cholesterol, high blood sugar levels. That doesn't happen anymore. We have medicines like insulin or oral medications which can keep blood sugars down to a reasonable degree, but they've been very disappointing in terms of lowering risk of heart disease in people with diabetes. Diet and exercise are really hard to be successful with to the point where you make your diabetes go away. I'm going to say only a little bit about these new weight loss medicines, Ozempic and Wegovy and Mounjaro. Very, very popular and very present in the consciousness now. These are medicines which work on a set of hormones between the gut and the brain and slow down emptying of the stomach and reduce hunger and can help with weight loss and control diabetes. And they work very nicely, but we're still learning more about these medicines. There are real side effects, some of which are not reversible. We are still learning who's going to be best treated with these and who best not to take them. And so I'm disappointed that these are being advertised on television by people who don't know the patients, because it's real stuff. I mean, it's not quite to the level of cancer chemotherapy where you would never just take it without somebody watching every dose. No, not at all. But you need a doctor to be in charge of that and to be monitoring those medicines. Really be helpful for a lot of people in the right setting, in the right place, with the right monitoring, and we will see going forward. So overall, staying healthy, try to lower your risk, shouldn't have to be that hard. It shouldn't have to be that complicated. We don't have to pay people to monitor our heart rate when we exercise necessarily. We don't have to buy a lot of expensive food, but attention to lifestyle and getting on the right medicines is really helpful. I hope we have time. I can tell you about two of my patients because they always make me laugh. So there's this guy named Randy, and he's a middle-aged guy, and he works for a tech firm. And half the time he works here, and half the time he gets sent to Shanghai. And when he lives here, he has diabetes. When he lives in Shanghai, he doesn't have diabetes. And this happened a couple of times. I said, Randy, what is going on? He says, well, over there, I don't have a car, and I walk everywhere. And I come back past the vegetable stands, and it's great. And I go home, and I said, oh, I get it. I'm going to tell people about this someday. And he loses 30 pounds when he goes to Shanghai. And he comes back, and he's 245 when he lives here. And he's doing DoorDash and, eating dicks. And so, it's just a little test case that walking and eating right helps. I got to tell you about another guy. He's so cute. You love him. His name is Ole. And so Ole's 86 now. And he has terrible blood vessels. He had bypass surgery. He's got 100 stents. His legs are all clogged up. He hasn't had a new blockage in 10 years. And so the other day, he calls me. Dr. Doucette, I've got to see you. It's an emergency. So I get him in. I say, Ole, what's going on? He says, you won't believe what happened. I got up in the morning. I ate my muesli like I always do. I cut down a tree with my chainsaw. I'm thinking, he's on the blood pressure, And then I went cross-country skiing. And I got passed by a woman. You've got to do something. So this guy, but he's totally motivated. He takes every medicine. He says, look at these medicines, what else can you do for me? And he walks and he skis and he eats his muesli in the morning. And it's just, he stopped the progression of this very aggressive disease. And now he's 86 and he's going to die in a chainsaw accident. It will only partially be my fault. So I'm going to stop pretty soon and then take questions. But I did want to spend a little time on what's going on here and how do I know if I'm in trouble. And so, there are symptoms that can tip us off that our heart's not getting enough blood flow, either subtly, chronically over time, or suddenly when we get a heart attack. And so we should know what's the difference between that and other kinds of discomfort we may have between here and here. So the usual, most common type of discomfort that people have when their heart doesn't get enough blood flow in men and women is a slowly gathering dull tightness or pressure or squeeze in the middle of the chest. Old Dr. Sam Levine out of Harvard, where I used to work, described this. It's now called Levine's sign, when people put their fist over their chest to describe their discomfort. That tends to correlate with it might be coming from your heart. A heart is slow and diffuse in its pain usually. And so it has to last at least a few minutes and is that constant, dull, inescapable pain. When people get out 1 or 2 fingers to tell me where the pain is, it's not there. So it hurt there, and it hurt there, and it was 2 seconds, and it was that. That's not going to be the heart. We have a different set of nerves out here. If I poke you with something sharp, you can say, hey, you got me right there, you got me right there. That's what those nerves can report. Whereas the inner organs like the heart are this sort of more dull, slow growing pain. And when the heart's not pumping enough blood flow, we tend to feel bad, we need short of breath, they get some nausea or sweating with it. Not all of those are present all the time, and it's not always right here. Sometimes people will feel it up in the neck or the jaw, can radiate, famously to the left arm. Sometimes people just get it in the arms, but it's sort of this dull, nagging, uncomfortable, something's wrong here type of pain. So in women, that can be more variable. More women than men will have an atypical, a not typical presentation where they may have less in the way of pain, or the pain may be just in the back or just in the jaw or arms, or they may simply feel a kind of indigestion and malaise and shortness of breath. And so these sort of more of the associated symptoms than the actual pain here. And so we are very aware of this. I mean, this is not a conspiracy to try to, not diagnose women with heart disease. And most women who come in with heart attacks are diagnosed on time and get the right treatment. But it is true that women show up on average later to the emergency room with a heart attack than men do. First of all, they don't conceive that they are at risk for this. This is not top of mind. They're worried about breast cancer or some other thing they think is going to get them. The most common killer of women as well as men is heart disease. So, women need to know that even when the symptoms may be a little atypical, they need to go in. And emergency room doctors and cardiologists need to cast their nets a little wider and think in a little bit more inclusive fashion where the wheels have to turn and you need to get that EKG, even if the story isn't quite classic. For more about why women feel the way they do in matters of the heart, we may have to ask the poets or the philosophers, but I did want to touch on that just a little bit. So this is maybe a good time for me to stop rambling on and take questions, because your questions are really what's important here. BJ.
I follow artificial intelligence and its application to various things.
Yeah.
And one of it is to healthcare. There's a company called Caristo Diagnostics out of UK that claims, looking at your CT scans, X-rays, stuff like that, they can predict if you're going to have a heart attack in 10 years. They filed for FDA approval here. But are you seeing any artificial intelligence developments?
Well, yes. I mean, certainly this is all on the way. And, there was a very interesting study recently that was able to distinguish pretty accurately if people were in congestive heart failure by listening to their voice. And, they have to do with fluid in the lungs and that sort of thing, but the AI was able to determine that. We're very excited about this. Certainly reading X-rays and reading CT scans, they're the things that we know we can look at, but AI can look at every pixel and can put that together without the preconceived notions that doctors have about what are we looking at and what can we see. One of the earliest studies of this that I saw was based on ultrasound pictures, echocardiograms, and this is a a student, he's still a cardiology fellow, and he did a study where he just fed a bunch of echocardiogram moving picture images in there. And with even a pretty basic AI approach, the thing was pretty accurate about saying, is this a man or a woman? How old are they? Do they have heart disease or not? And could look at that. So, you know, BJ, I haven't heard about your particular company, but it's coming, and we are really happy. And you know, we always struggle for ways to be more accurate at diagnosing what's going on now and predicting what might happen 10 years down the road.
2 more questions, if I can.
Please.
Rapamycin. Easter Island, for some reason, has very low heart disease. So that's why they're Rapaport, you know, Rapa Nui.
Yeah.
So the NAD+, is that something that is useful?
Not for sure, and not to the point where we can advise people to put it in their body. We have to have a pretty high threshold for recommending that, so not right now.
Can you explain what DEXA scan is?
A DEXA scan? Yeah, so a DEXA scan is an X-ray measure of bone density, which is usually used to identify osteoporosis, which is the sort of age-related or medicine-related loss of bone that happens in people as we get older. And so, you know, most commonly this is a problem in women, postmenopausal women who, once they lose natural estrogen, start to lose bone density. And so a DEXA scan is part of their usual checkup.
Is that tied to the heart?
Well, only peripherally. You know, calcium metabolism is important. We want it in our bones and we don't want it in our blood vessels, and keeping the two apart is a challenge. But we, you know, so we don't specifically use a DEXA scan in heart disease. We kind of bump up against the bone doctors a little bit when we talk about calcium supplementation, because adding calcium can help strengthen your bones, but it may end up in your arteries, it may increase your risk of blockages there. And what we have learned, at least our current understanding of this, is that soluble calcium that we get in dairy products and in kale and other dietary sources doesn't increase heart disease. And it's just as good for your bones. Whereas, you know, get a Tums or a calcium carbonate pill may be harder on the heart. So that's what we advise people. Yes, sir.
Yeah, I keep trying to learn more and more about my heart area, and it's kind of like the more I know, the less I know.
Yeah, you know, here too.
Then how about this statement? A cardiologist is more art than science, being a cardiologist. Is that true or false?
Well, I'm going to go for 50-50. I think that without the science, we can convince ourselves of all sorts of things that we regret 5 years later. You know, that without knowing what we're doing, we can't help people as much. But certainly the ability to connect with another person and do what I call getting them to want what you want them to want is much more of an art. We recommended cholesterol medicines for years that turned out to make the numbers look better, but never really lowered the risk of heart attack or stroke. And recently, lots of money was lost by big pharmaceutical companies in creating medicines that increased the level of HDL, the good cholesterol in the bloodstream. Did a great job at that. Didn't make any difference in heart attack or stroke or death. So those medicines went away at the loss of hundreds of millions of dollars. That we need science. Yes, ma'am.
Would you address AFib and low blood pressure versus high pressure?
Yeah, so atrial fibrillation is a big complication or a big story. very common irregular rhythm. The normal heartbeat starts with the control center telling the atrium to push blood through the valve into the ventricle, and then the ventricle pushing the blood out. And when the atrium gets out of sync and each muscle cell ends up twitching on its own little timer rather than all pulling together, then we call that atrial fibrillation. It leads to two main problems. Number one, blood can clot in the upper part of the heart because the blood isn't flowing through with each beat, which can increase risk of stroke. Then number two, you don't get the same efficiency of blood around the circuit, so people can feel lightheaded, tired, out of breath. And so atrial fibrillation is a big deal.
And that's what happens when you exercise, AFib happens.
Well, it shouldn't. You know, you shouldn't get atrial fibrillation when you exercise, and it's a problem if you do. So that's something to look into. Yeah, and low blood pressure, your blood pressure should really be just high enough to keep you awake and keep you not dizzy. You usually need a top number on blood pressure of 100 or more, or you start to feel like you're gonna pass out. But anything above that is sort of gravy. Yeah. Yes, ma'am.
What's the relationship between alcohol and heart health? Or cholesterol?
Oh, yeah. So I'm gonna get kicked out. Alcohol is not your best friend with your heart. You know, the studies in the old days that kind of looked at, a glass of red wine will raise your HDL. Or it turns out raising your HDL, it's not a huge bargain, as I said. So alcohol can raise your blood pressure. You can think of it as an added sugar. So in terms of, help your diet, it's a little like drinking a Coca-Cola. As my wife likes to say, alcohol is a gateway drug. It leads to nuts, cheese, all sorts of, eating all sorts of things we wouldn't otherwise, and it ends your exercise for the day. So I don't have any problem with alcohol in moderate amounts being a part of your lifestyle. Too much alcohol causes atrial fibrillation, certainly, and it doesn't move the ball forward in a big direction. So it's something to enjoy. I already said that dinner time should be a celebration and an enjoyment for everybody, and a glass of wine or beer with a dinner, can be part of that. But it comes in a little bit of a cost.
Would you see if, like I did dry January, and I'm continuing with dry February.
Yeah.
But I saw a reduction in my cholesterol, which was kind of surprising to me.
Yeah.
My good stuff went up, my bad stuff went down.
Yeah.
So that's pretty.
That's something we typically see.
Okay.
That's something we typically see. Yes.
I'm going to say a little bit about myself. I'm one of those, I think, doctors call me a complicated case because I have all the bad history.
You are welcome here.
I follow up with a cardiologist on a regular basis, and I love him dearly. And but I have a very high family history of heart disease, diabetes. I mean, you name it, I have it. I try to do the best I can, and working out or whatever, and watching what I eat. And I still have. I don't have high blood pressure, thank goodness, knock on wood, but I'm on that borderline of diabetes. I have worked out to the point where I work out 7 days a week, high impact aerobics. It still didn't raise my healthy cholesterol levels and either my cholesterol levels.
Yeah.
So I was on cholesterol medicine for almost like 25 years.
Excellent.
And then I started having the problems of really bad, to the point where I couldn't even walk.
Sure.
And I was getting other side effects too from it. Stopped that, and eventually that all went away. So now we're just watching it, and I get the CT scans of my heart, and everything's good, but, you know, it's like, is there anything else? I mean, my doctor has just now started me on that one cholesterol medicine. I can't remember what, you said there are other cholesterol medicines. It was the first one.
Yeah.
You said it's cheap, but it's.
Yeah, maybe it's Ezetimibe.
Is it? Yep,
Yeah,
that's it.
yeah.
Yep, that's one. And so I'm just wondering, you know, is this lipid protein A something I should have my doctor check me for? Is that also something that I should be looking at to help?
So many families who inherit coronary disease, not all of them, but some of them have this lipoprotein A. So we're checking one time. Certainly, if you're not on cholesterol medicine now, you have elevated lipoprotein A, then there would be an indication to get that down. And you know, what you really need is somebody to assess your risk overall, you know, looking at all of you as a whole person, and then deciding, is there a benefit to you to having a lower cholesterol, in addition to all of what sounds like really, really hard work on your part?
Yeah.
And if so, send it back to the shoe room and find a medicine that works for you. And, you know, if you try, you know, you got 25 years out of statin therapy, great, you look terrific, you didn't have a problem.
Yeah.
But if that's out now, then good, because 25 years ago, we didn't have all these other options.
Yeah.
And so get what you need and get on it and make sure it works and spit it back at him if it's no good.
Well, so far that is Zetamide.
Yeah.
I've just started taking that, and so I haven't noticed anything, but he's gradually working me up on it, so we'll see how that goes.
So, you know, the principle here is both of you need to be hard-headed and get you to a safe place, no matter how many times you gotta go back and forth, and everybody keeps a smile on their face, and you know, you find your happy place eventually.
Yeah, because my brother just was here.
Oh, yeah.
Dr. Riley just,
Yeah.
you know, he had a complete blockage in the left artery, and he was able to go in and put 3 stents in him.
So not allowed for you, so, right.
Yeah, I don't want that.
It sounds like you're on a good track,
Yeah.
and somebody really good watching. Yes?
In terms of cholesterol numbers, I know whenever I do an annual blood test, you know, they come back with the HDL and triglycerides, and then LDL is always calculated. And I'm curious, how accurate is that calculation of your LDL levels?
Yeah, kind of accurate. Yeah. So LDL is hard to measure directly, and so we use this formula that was made up by a doctor scientist a few decades ago, where we can look at the total cholesterol, the triglyceride, and we know that most of the triglyceride is in something called very low density lipoprotein, or VLDL, and we know that that's about 20% cholesterol and 80% triglyceride, and then we can measure the HDL, and we can calculate how much has to be LDL, because it ain't anything else. And so we use that calculation. And so that has been the way that we've traditionally measured LDL cholesterol, is by saying, you know, if we got a pie and this 3/4 of it we can see, then it's got to be that quarter of it. And it's pretty accurate. It's getting easier and easier and cheaper to measure LDL directly. And sometimes in some labs, you'll see the calculated and the direct, and will be off by 3 or 4 points. So for most uses, it's fine. There are other, we don't get too far into it, but there are other predictors of risk, something called ApoB, apolipoprotein B100 is a carrier protein which makes the cholesterol, which is a fat, soluble in the liquid phase of the blood, or the water phase of the blood. And by every LDL particle and every bad particle has one ApoB molecule on it. So I measured the number of ApoB, we can tell how many bad molecules or bad particles you have. So ApoB is a way of checking that. Direct LDL is a way of checking that. For most purposes, the cheap and dirty calculated LDL gives you all the information information that you need. PJ?
Do you measure the large particle ones versus the small? Because the small ones are the ones that get stuck into the wall.
Right, so sometimes, it depends on the situation and it depends on the person. And so he's talking about looking directly at the sizes and density of the LDL particles that I mentioned earlier in the story. It really looks like the total number of LDL particles is important. If you have a lot of them per the amount of LDL total, that means they're smaller and denser. So we measure that sometimes. It doesn't always become clinically relevant. It can be really helpful if you have a person who has a heart attack and you put them on medicines and then they have a heart attack. And that's not very common anymore, but if you're having somebody who's showing progression of atherosclerosis, despite you having plugged all the holes in the boat that you think you should, then we look for special stuff. Yes?
What specialty of physicians should we go to have the whole body assessed as the prior lady that you suggest have someone assess? For example, if somebody has severe osteoporosis and also cardiology issue, I'm sure, with all kind of statin medication. So what kind of specialties should we look for?
Yeah, we should start with your primary care doctor or general internist, which is a person who has the responsibility for keeping us all out of trouble and looking for warning signs and places for further investigation. And the specialists usually get involved once there is trouble. So a really good general internist is a fabulous thing to have in your life. And then for specialized things, medicine has gotten really big, and our heads are not any bigger than they used to be. And so nobody really has the ability to be an expert in everything. I'm not great at osteoporosis, and the bone doctors are not terrific at atrial fibrillation. And so I wish that person existed for you. But start with your general internist and make sure you get a thorough look at all these things, and then go where the money is after that.
But I find primary care, I feel I have a very good primary care physician. But a lot of things, this primary physician would refer to, for example, cardiology, other specialty, because she's not the specialist for everything.
Right.
But I find it must be very difficult for the primary to have time, especially in nowadays environment, to really assess. So how do I request that?
Yeah, I think just the way you did it. It is very humbling being in business and trying to keep people healthy, because there are 100,000 ways that things can go wrong. It's hard to spot those in a half-hour visit. And I think that what you've done really is a very eloquent way of advocating for yourself and saying, look, I'm concerned about these things, and I have the interest, and I'm one of your patients who actually cares if I stay healthy or not. And what do you see here, and where can we go? Where am I going to get the biggest bang for my buck? Unfortunately, as I said, very humbly, you're not going to find one person who knows everything about all of medicine anymore. Yeah.
Exactly. So I'm satisfied from what I learned today, especially when you talk about calcium supplement and, for the calcium in the heart. I suppose what I learned today, just keep seeing my primary doctor more and more often to get this point across, because their time is so limited.
Sure.
So,
I think that's really
all right.
That's really true. And there are more hurried doctors than there are bad doctors, I think, today.
I think to me, I interpret it as the institution. Their time is limited, they have to really tie their nose.
Yeah.
Otherwise, they stay all night after work to get the
Sure.
visit summary and all that.
Yeah.
So a lot of time when I read the review of the patient, they always say, my doctor always looking at the screen tying at the nose. But I think it's the environment of the institution, clinics, medical center, some sort. So I guess it was helpful, your talk. So I will keep going to my primary doctor
There
very
you go.
often.
That's all right.
You know,
Keep knocking on the
every
door.
20 minutes, adds
Yeah.
up.
Yeah, that's great. Yes, sir.
Just a quick two-part question. We principally climb stairs as a form of exercise.
Great.
And is that, part one, is that good for your heart? Is that a good exercise?
That's very good.
The other
That's
thing,
very good.
is there a rough equivalence between 200 steps and one flight of stairs, or some kind of relationship that you?
Well, do you know that same study that I was talking about earlier, where 2,500 steps moves the needle in terms of making it healthier? In that same study, they were able to show that the cadence of your steps made a difference as well. So if you're walking fast, bam, 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 you get more credit. And going uphill has to be the same thing. So, I mean, even in the sort of physical activity recommendations of half as much intensive exercise counts the same as twice as much moderate exercise. Going upstairs, you're doing intensive exercise. So, maybe 2 to 1, I don't know, it depends. But certainly more vigorous exercise is really good. The main thing we all have to be careful about is staying healthy. And, I said you didn't have to pay somebody to count your heartbeat. The only reason to have a physical trainer or some advice is so we don't hurt ourselves. Repetitive stress injuries occur, and, a lot of times people will say, okay, I'm gonna work out, and then all of a sudden I'm taking 6 weeks off because I have plantar fasciitis or something like that. And so you should exercise as much as you can, as much as you will, but you should do it at a sustainable rate. The most important thing is your consistency, and then intensity comes in as well. But I love it going upstairs. Yeah. Yes.
So in terms of heart rate, they always have a target heart rate based on your age. And
Yeah.
if you exceed that, most people
Yeah.
are relatively older. I mean,
Yeah.
so is that a problem for your heart?
Not at all.
It's just when you can't breathe anymore, it's like, okay, I better ease off.
That's exactly it. So even people with bad heart disease, 99% of them can exercise up to the maximum heart rate they can achieve, and they're not going to hurt themselves. Those target heart rates are really looking at your aerobic threshold. When you are exercising below about 85% of 220 minus your age, which is sort of the target, that is a rough idea of how fast you can metabolize sugar all the way down to carbon dioxide and water and blow it off. If you go faster than that, so if you get your heart rate up very, very fast, you're snapping sugar in half and throwing it aside. That builds up lactic acid in your muscles and you can't go. And that's why we can only go 100 yards at our fastest with a heart rate of very, very, very high, because our legs will stop. And so those targets are really only if you want to exercise for a half hour, you better keep it down under there or you're gonna run out of gas. There's nothing wrong with exercising harder, you just gotta slow down. And then once your muscles clear out that painful lactic acid, then you can go again. But there's no safety concern with exercising up to the highest you can get. Thank you so much.
Thank you.